Thanks everybody for joining us this morning. It's a fantastic little presentation we pulled together. It's the NECOM, MARCOM. It's a mini toxicology conference. And we were very grateful for you to spend your Saturday morning with us. My name's Chris Spicer. I direct continued education and outreach for the Region 3 ERC that's housed at Johns Hopkins University. We support research, training, and occupational health and safety for Maryland, Virginia, West Virginia, Delaware, Pennsylvania, and Washington, D.C. Um, and we have teamed up with NECOM to put this together today. With all that ado, some of the semantics about online presentations and virtual conferences, I'm sure we're all familiar with. If you'll don't mind staying muted for the duration, um, have a question or a comment, feel free to raise your hand, put that into the chat. I'll monitor the chat. The presenters, as we go through, if they want to acknowledge conversations or hands in real time, I've left it up to them. Otherwise, I'll keep track of who's got their hand up and what's been put in the chat for when presentations end, and we go into a little bit of. With all that out of the way, I'd like to hand it over to Romero Santiago for a brief presentation to everybody.
Thank you so much, Chris. Yes, my name is Romero Santiago, and I'm a member of NECOM's Education Committee and Board of Directors. And on behalf of NECOM and MARCOM, our entire partnership, just wanted to briefly thank all of you for, as Chris mentioned, spending your Saturday morning with us. And a special thank you to our speakers, many of them, hailing from all parts of the country. I think that's the benefit of the virtual setup, where we really can get the best of talent and the best of expertise here with us. So a special thank you to all of our speakers today, and I really think all of you are going to enjoy this event. And I just wanted to briefly mention the spirit of this event from the toxicology standpoint is, given our field of occupational and viral medicine is so interdisciplinary, and we collaborate across the aisle with industrial hygienists, audiologists, attorneys, HR, really, and one of the big pushes in our field of OEM is really better delineating and expanding on the environmental medicine piece of our specialty. And so a huge core of that is in the underlying principles of toxicology. And so in that spirit, if not for the unfortunate actions from the executive branch in terms of some of the last minute changes that happened, and very grateful for our speakers for adjusting kind of the initial spirit that I had, that hopefully we can sort of resurrect as time progresses, is, we know in this space of toxicology and OEM, the governmental branches of NIOSH and OSHA, specifically NIOSH in terms of the toxicology aspects, there's a huge value of that partnership of creating forums where the governmental agencies can interact with us as clinicians. And in addition to that, like you're going to see in our presentations, we have industrial hygienists, audiologists that we collaborate with as well. And so we realized, the greater theme here is the importance of creating this forum where all of us as occupational and safety health professionals can really come together and listen across the aisle and have that structure to really share how we can optimize our collaboration in these unprecedented times, just with everything from natural disasters that Dr. Berenji will talk about at the end in terms of everything's going on in California, to ways that various environmental exposures are not only affecting our workers, but the overall community as well. And so I think that was really the spirit of why we thought about this type of event, to create that opportunity for not just the physicians or the OEM practicing clinicians, but also the other professionals that we work with to come together, and for us to really think in real time of how we can expand our collaborations. And even when we're faced with a clinical situation, what's that first response? How can we reach across the aisle and get our colleagues engaged in a way that is meaningful, not only for the patient, but also to optimize our specialty going forward? So, with that said, it's been very valuable partnering with Chris and Keith at Johns Hopkins ERC, as well as Chris had mentioned, the education mission that is there. We also have that same education in terms of us as the physicians. So with all of that said, very, very grateful to our speakers and to all of you for taking the time to be with us today. And without further ado, I will pass it on again to my colleague, Chris, to kick off this meeting.
Thank you very much, Romero. So our first presenter today will be Dr. David Nierenberg, joining us from the Geisel School of Medicine at Dartmouth. We're looking at a case study of a 48-year-old woman seen by the primary care provider with a chief complaint of new onset ataxia. Looking forward to hearing from you, doctor.
Okay, thanks very much for the invitation. Just confirming, can you hear okay now?
Yes.
Okay,
Yes, sir.
so thank you for the invitation. I know I'm filling in for a speaker who couldn't do it at the last moment. My background is a physician trained in internal medicine and then clinical pharmacology and toxicology. But the case, a real patient that I saw a few years ago, gets also into the areas of environmental medicine and occupational health. So I hope it will be of interest to all of you. It's in the format of an old-fashioned Department of Medicine grand rounds or clinical pathological conference, where we start with a discussion of the patient and then go wherever that leads us to go to try to understand what's going on and then hopefully treat, and in some cases, hopefully cure the patient. And the patient was a 48-year-old woman seen by her primary care provider with the chief complaint of 4 days of new ataxia, which for her, as an ardent athlete and a very, very good rider and horsewoman, meant when she walked down the stairs, she was stumbling and could only do it safely holding on to the handrails, which in her 48 years of life, she had never needed to do before, and also stumbled just when walking across the room. So difficulty with balance and what she described as a drunken gait. Ironically, in January of the year, so this is almost exactly the anniversary of when she presented, she had to grasp the handrails on the stairs. She drifted into walls when walking down a hallway. In a narrow hallway, she would bump into the wall on the left and then 3 steps later, bump into the hall to her right. Previously, as I mentioned, she had had no such problems. So,
Dr. Nierenberg,
yes.
sorry to interrupt you. Did you need to share your slides, your presentations? Because we're not seeing them in the Zoom.
You're
If you
not
were,
seeing them, okay? I am trying to share the slides and I hit, are you seeing that now?
no, sir.
Because when we logged on before, hold on one sec. Let's try it this route.
There we
Yeah.
My
go.
desktop now.
It's coming close.
Desktop is showing.
How about when I hit this, my first slide?
You're in good shape now.
Okay,
There we go.
thank you so much
Thank
for letting me know before I got beyond the first slide. I appreciate
Good to
it.
go.
So the local physician confirmed the marked ataxia, the stumbling and discoordination, and referred the patient appropriately to neurology at our medical center here in the central of New Hampshire. And here's the information she gave on admission. She came in for a 5-day inpatient evaluation. She was a faculty member at a New England college and briefly 4 months ago had a minor episode of nausea, vomiting, and diarrhea, lasted only a couple of days, probably was a viral gastroenteritis, had not recurred. 2 months earlier, she had traveled to Malaysia. She was a professor. She went there with a couple of colleagues for a conference in her field, but she had not become ill there and nobody else became ill, so they weren't worried about pufferfish toxin or anything like that. She had a few other symptoms on that early presentation. She had lost about 15 pounds of weight unintentionally over the last 5 or 6 months. And in addition to her stumbling gait, she also had slurred speech. So she was trying to speak like this, not quite that bad, but clearly slurred speech. Also noticed she had brief flashes of light in her vision that occurred randomly and sporadically, and ringing in her ears. So her neurological complaints were the ataxic gait, the unintentional weight loss, recent slightly slurred speech, and brief flashes of light. She was not taking any medications at this time. On physical exam, she appeared healthy with slight recent weight loss. She smiled and joked, was very oriented, totally oriented, very communicative, and very concerned about these new neurological complaints. She had no idea where they were coming from or why. She was lucid, entirely oriented, excellent short and long-term memory, so her mental status at that time was absolutely normal. Her vital signs were normal. Bedside testing of her vision and hearing were normal, although they would deteriorate a few days later. Her neuro exam showed this truncal ataxia, that's the stumbling and poor balance, the slurred speech, the poor handwriting, which was new. She was brought up with elegant script handwriting, and when I first met her a day or two after this, it was very hard for me to be able to read her name when she used that beautiful script handwriting. Well, the team that admitted her rounded up the usual suspects. So I'll go through these for those of you who may not be physicians. The CBC is a complete blood count, absolutely normal. Comprehensive metabolic panel looking at renal function, hepatic function, absolutely normal. No sign of any organ damage that might cause confusion or neurological problems. Thinking that this discoordination might be somewhere in the brain, they did a CAT scan of the brain, totally normal, no areas of damage or inflammation. A more sophisticated, more expensive study, magnetic resonance imaging or MRI scan, was also done when the CAT scan was negative, totally normal. And although this did not sound like a viral or bacterial infection involving the brain, spinal cord, or brainstem, a lumbar puncture was done. And once again, I won't bore you with the details. Suffice it to say, it was absolutely normal. So no clues coming from the usual investigations of patients who come with an acute several-day history of what sounds like a progressive, getting worse every day, neurological problem, probably located somewhere in the brain or brainstem. A little bit of her social and occupational history. I mentioned before, she worked as a professor at a college in New England. Her research involved environmental toxicity of heavy metals in animals and humans, how those heavy metals got into the environment, and how they might affect once in the environment and once contaminating the environment, animals and humans. And almost as an afterthought, while I was interviewing her in January, she recalled that 5 months earlier, in August of the prior year, she had a very tiny spill in her lab and mentioned it only to be complete and helpful, but didn't think it had anything to do with this. And I'll describe that for you right below on this same slide. She was working in a fume hood, as suggested, wearing the usual lab gloves, the usual white latex rubber gloves, as suggested for this chemical, transferring a liquid form of a heavy metal from using a Pasteur pipette with a little yellow bulb on it into an INR tube so she could do INR spectroscopy on that clear liquid. And what she recalls happening was those of you who work in the lab and have used those little Pasteur pipettes with a narrow tip and also the little yellow bulbs, they usually fit on quite well, but this one didn't quite fit quite well. And while she was in the middle of pipetting, she thinks she dropped maybe 5 or 6 little small drops onto her gloved hand in the fume hood. So she quickly emptied the rest of that content back into the vial, sealed the vial, discarded her gloves, put on clean gloves, kept the fume hood going, wiped down the fume hood, and stored the wiped down paper towels in the fume hood so they would not contaminate the air in the room. The clear liquid that she was pipetting, she recalled as being dimethyl mercury. But it was a tiny amount, and she was gloved, and she was working in the fume hood, so she didn't think it had anything to do with this. And anyway, it was 5 months earlier, so how could it? So that got us interested in, with that bit of history, and also with the neurological presentation with the ataxia, the discoordination. Could this be heavy metal toxicity? Because not only was that tiny spill onto a gloved hand 5 months ago in the fume hood, but her lab routinely investigated, and her research grants called for investigating the toxic effects of lead, mercury, arsenic, and cadmium on the environment. However they got into the environment, we'll get into that a bit later. She just wondered whether a tiny spill 5 months earlier could somehow be related. So we did send off our typical heavy metal screen. We don't do it locally. It's done by very expensive and sophisticated techniques. We mailed it out to Mayo Clinic and got the results back a couple of days later. Looking at especially lead and mercury, of these, they can have CNS, meaning central nervous system or brain toxicity, although this was really a long shot. You all know more recently about lead contamination in contaminated rivers near Chicago, leading to a whole neighborhood of children drinking out of their tap water that was contaminated through their lead pipes. And mercury also has a long history dating back to when we recognized mercury toxicity in hatters who made felt hats and got contaminated with mercury used in the preparation of those hats, leading to the term Mad Hatters. So what forms of mercury are most commonly encountered? Well, I'll tell you a brief story about each of these, but there's elemental mercury, mercury being a metal, one of the few metals that's liquid at room temperature, also called quicksilver mercury, the way it slivers across a Petri dish that you see here. Very likely to evaporate if a spill is not cleaned up. And I've treated several patients actually as a toxicologist who not only inhaled mercury, but several who broke open thermometers. They had psychiatric issues, poured the mercury into a syringe and injected themselves with quicksilver mercury. One injected herself into her vein and had hundreds of little tiny mercury globules of liquid mercury in her lung that you could see on the chest x-ray. The other injected himself in some fatty tissue on his leg, and the surgeons, using scuba gear so they didn't breathe the fumes, took her to the OR and were able to cut out that contaminated tissue. Mercuric and mercurous chloride, like mercury Cl2, is highly toxic when ingested orally to the gastrointestinal tract. And I admitted a high school student a number of years ago who, when his girlfriend broke up with him, swallowed a bottle of mercuric chloride from his high school chemistry lab. I don't know how many of you know about that. I didn't at the time. I had to check on it. But he developed 6 months of renal failure, was on dialysis for 6 months because it was poisonous to the kidneys, and also sloughed the lining of his GI tract. And finally, what we thought we might be dealing with here was not ionic mercury or elemental mercury, but organic mercury. And that's when mercury has a covalent bond, usually to one methyl group. We call that monomethyl mercury, or this rare chemical that none of us had ever heard of before, dimethyl mercury. Ironically, she purchased it as a lab reagent to help with her NMR spectroscopy, bought it through a national supply house for lab chemicals, I think it was Sigma, who purchased it from a man who cooked it up, synthesized it in his garage. Ironically, he lived in New Hampshire at that time. Now, this is not the mercury that I'm talking about. This was the quicksilver liquid mercury. This, ironically, the same time I was seeing this poisoned patient, this high school in Randolph, Vermont is 20 miles from where I was living. They had to clear out their high school for a week because the carpeting on the floor of the chemistry lab was contaminated with liquid mercury, and it was a volatile liquid, and it was degassing and contaminating the whole high school, and had to clear everybody out until they could remove the carpeting in a safe fashion, wearing respiratory apparatus, and get rid of that source and air it out. And you'll see here, sometimes when you're dealing with a patient that brings a problem to your attention, all of a sudden you notice more about related articles in the local newspaper. So this was confusing to us, confusing to the team. They called in our service, clinical pharmacology and toxicology. And when I saw her back in that brief inpatient stay, I felt that her ataxia and dysarthria were consistent with mercury neurotoxicity because it likes to seek out, for reasons we don't understand, the cerebellum, the lowest part of the brain, just about the brainstem, that really is responsible for our coordination issues. But when I pulled out the toxicology textbook of toxic chemicals, I looked up mercury. This didn't really fit very well with elemental mercury toxicity, with monomethyl mercury toxicity, with a problem and a spill that happened 5 months ago. And there was less than half of one paragraph that talked about organic mercury, and that was confined to monomethyl mercury. But that had some overlap with patients who had been poisoned with monomethyl mercury, with what we were seeing in our patient. On the other hand, back when this happened in 1997, we didn't have computer searches like we do now. And when I looked up organic mercury in Index Medicus, there was very little that could guide me at that point in 1997. So here is a summary of Ellen Horn's toxicology. Like I say, at the top of the screen in white, they talked about all of those poisonings she did not have and devoted only half of one paragraph to monomethyl poisoning, which was specifically tropic to the cerebellum and to some extent the rest of the brain. And they gave me a tip. They didn't see much about it. They mentioned an outbreak of organic mercurial contamination that happened in Japan when the bay of a city in Minamata, Japan, called Minamata Bay, got contaminated with methyl mercury. And I finally was able to track down an article that talked about the disaster in Minamata, Japan. And I'm just curious, has anybody heard about that disaster? Yeah. So in this audience, I see a couple of people shaking their head. I had not, but this was 1973 Japan, when a lot of babies, recently born, and children, some adults, and a lot of cats, not so much dogs, but cats, really came down with severe discoordination, abnormal posturing, like you can see in this child, inability to walk, and a number of people died. One of the clues was who got the severe poisoning, and the cats tipped us off that it was people that got, in this bay, almost all of their protein from fish, and the fish in the bay were contaminated with monomethyl mercury. How did it happen? Well, there was a chemical company right next to the bay that used mercury, monomethyl mercury, as a catalyst in the production of fertilizer and acetaldehyde. And they dumped the waste, once they were done with the catalytic process, directly into the bay. The bay was huge. It fed into the Pacific Ocean. It would, they thought, dilute things away. But a lot of it settled to the bottom of the bay, got into the plants, got into the fish, got into the smaller fish that ate the plants, and the medium fish ate the larger fish. And what they used mostly for protein was catching local tuna, which bioconcentrated the mercury that was in the middle fish, that was in the little fish, that was in the water and the plants. More than 2 million people were affected with this disease. More than 2,200 were seriously harmed, and almost 2,000 died. There was a big settlement where the company begrudgingly admitted that they caused it. At first, they denied it, and there was a settlement. I could not find out the details in dollars. And there was a video when I checked a few months ago, if you care to watch or Google it, of how severely abnormal their gait, their balance, their dystonia was, clearly with damage being done to the central nervous system. They were developmentally delayed and severe damage to their center for coordination and gait. And then here is just a summary of what's just described to you. So the Minamata episode, when I was able to read about it, made me think that, okay, monomethyl mercury could get into the brain. It's highly organic. It's not highly charged. It depends what the second R group is. What about dimethyl mercury that was the reagent in our patient's lab? Well, that to me looked more lipid soluble than monomethyl mercury. So if anything, I hypothesized, would be more likely to rapidly cross cell membranes throughout the body, be more lipophilic than monomethyl mercury, and more easily and quickly get through the leptomeninges, the lipid layers and membranes that protect the brain, and get directly into brain parenchymal cells and tissues. Hypothetically, that might be even more able. And also hypothetically, this was just a supposition on my part, I had no idea if it was true, if somehow, and I didn't know how, those few drops of mercury, of dimethyl mercury, somehow were able to get through her protective gloves, this stuff, this chemical, might be lipophilic enough to directly penetrate the skin the way a number of medicinal products can be applied to skin and get into the soft tissues below the skin. So I wanted to learn more about this strange chemical that I had never heard of, but it was in the Merck index, molecular weight of 231. Almost all of that weight, 87% of it, is mercury by mass. The two methyl groups, although substantial, can't stand up to the molecular weight and the mass of mercury. It's a colorless, extremely volatile, toxic liquid. It's also easily flammable. Its boiling point is 92 degrees, but even at room temperature without boiling, it has an extremely high vapor pressure. So even a few drops spread in the fume hood could easily and quickly evaporate. It's also very dense. Water, as you know, has a density of 1 gram per milliliter. This has 3.2 grams per milliliter. So I did a quick calculation on the back of a piece of paper. What if she had spilled 0.1 milliliters onto her gloved hand? Well, that would contain 0.32 grams, of which 0.28 grams, or 280 milligrams, would have been mercury. That sounds like a tiny amount of mercury, but if it was in the form of dimethyl mercury, which was arguably much more toxic than monomethyl mercury, which poisoned a whole city in Minamata, Japan, just by getting dumped into the seawater, maybe that's what was going on here, but I so far had no hard evidence of that. At that point, she was discharged home awaiting lab test results. And I figured if it had gotten into her, that getting in phase must have been over in a few days or weeks at most. So she was discharged from the neurology service with a diagnosis of acute cereballitis. Well, that's a term that doctors make up. If there's inflammation, you think in an organ, just add itis to it. Neuritis, cerebritis. If the cerebellum is affected, acute cerebellitis, an itis of the cerebellum. We didn't know the cause, but we were starting to think we were focusing in on organic mercury toxicity. And she was beginning to note rapidly progressive, day by day difficulty with speech, walking, hearing, and vision. Hearing was getting worse with bedside testing, and vision was getting worse. Interestingly, I don't know how many of you have ever used up a roll of paper towels in the kitchen, and you have that long gray cardboard tube, and sometimes your kids like to walk around looking into that tube. You may have tried it. I know I tried it. That's called tunnel vision or constriction of vision, and that's what she had. I deleted the slide that showed her eye testing, but her vision covered only what you would be able to see looking through one of those 12-inch cardboard tubes of paper towels. So there was clearly damage being done either to her retina or more likely to her visual cortex in her brain. A few days after she was discharged home, the Mayo lab called to say that the whole blood mercury level was very high. They had not quantitated it. It was so high they had done 6 serial dilutions and it was still off scale. So all they could say was it's the highest level of mercury in blood we have ever seen. We'll call you back in a day or two once we have a quantitative result. The patient was immediately phoned and called in for general medical support. And now that we had confirmed mercury, chelation therapy. So eventually, a day later, they called back and said that her whole blood mercury level, which they did not speciate, was 4,000 micrograms per liter, which is the normal range is 0 to 10. So that's 400 times the concentration of mercury in her blood than you would see in a healthy patient. Occupational health and safety would say that if you're working on a job site and you're potentially exposed to mercury vapor or mercury in your cleanup, you should have your blood level checked every week or two. And if your blood ever gets to 50 micrograms per liter, you should be pulled off the job site. And I note that mercury in blood is measured as mercury and is not speciated. Later on, we were able to speciate that and confirm that it was definitely partly methylmercury and possibly, and I think much of it may still have been dimethylmercury, but we didn't know that at that time. Her blood concentration, and blood is full of lipids and cells with lipid membranes, was 4,000 micrograms per liter. Her urine mercury concentration was 234 micrograms per liter, normal less than 20. Acceptable industrial exposure, because mercury likes to come out in the urine, less than 150. But the clue here to me at that time, going back to my college organic chemistry course, where we were given an unknown chemical and we were trying to partition it between an aqueous layer and an organic layer, her ratio was 4,000 units to 234, or 17 to 1. That was a strong clue that the mercury in her blood was covalently bonded to some lipid-soluble organic groups. We later were able to prove that, but this was our clue with the crude testing that we had at that time. Over the next 6 days, there was rapid progressive deterioration in her gait, speech, vision, and hearing. New and rapid deterioration in her cognitive function. She could no longer speak clearly. We could barely understand her. She could answer yes and no to questions. That was about it. Chelation was begun immediately, 4 days after she had presented to the clinic, as soon as she was called back to the hospital, and increased her daily urinary output from 257 micrograms excreted per 24 hours in her urine to 40,000 micrograms per 24 hours. So that would be 40 milligrams per 24 hours. So there must have been a lot of milligrams in her to start with chelation and get 40 milligrams out per 24 hours. But which chelator to use? I show on the screen, those of you treating patients are familiar, but for those of you who aren't, I'll spend just a minute going over chelators. The good chelators for the heavy metals tend to have two active sites. The carboxylic acid sites, and most of them have one or two of these, are a COO minus at physiologic pH, which makes that side of the molecule water soluble, and it's a small molecule, so it's easily filtered and excreted in the urine. The one or here, or better still, two sulfhydryl sites are there for the purpose of covalently binding to the heavy metal. And you notice that most of these oral chelators, these are older ones. British anti-leucide has been around for many, many years. D-penicillamine also. Dimercaptosuccinic acid is a much newer one. It's been around about 25 years and was available when I saw her. There was no evidence, and it wasn't FDA approved for use with what we thought she might have with mercury, but it was approved at that time for lead poisoning. I later found evidence from a 1971 episode of mercury poisoning I'll tell you about in Iraq. I'll show you how that happened. These two chelators had been tried way back then, and they had not helped at all. So given that, and given that although it wasn't FDA approved for this, you were allowed to use it for this, I thought that might be better because at least it hadn't been disproved. By this time, here is her visual fields. You should be, if you can see my pointer, seeing all the way out to the sides of your body. Here are her two little fields of vision looking down the 12-inch long tubing. Ironically, the same day we discovered all of this mercury in her, my local medical journal called my local newspaper, the Valley News, had a study finding that the region's loons were dying off from brain toxicity of organic mercury, in this case, monomethyl mercury. How did it get to our beautiful lakes in New Hampshire? A lot of mercury in thrown out blood pressure cuffs, thrown out mercury thermometers, sometimes light bulbs, go into coal-fired power plants in the Midwest. That goes up into the atmosphere. The winds blow from west to east. We get their rain, and we call it toxic rain. And the toxicity not only alters the pH in our lakes, but increases mercury in our lakes, taken up by plants. Plants are eaten by the small fish. The loons eat the small fish and die of brain toxicity of monomethyl mercury in their brains that we get from the rain that picks it up from incinerators in the Midwest. So ironically, the same day we discovered it in her, there's this article in our local newspaper. What about the Iraqi epidemic of 1971? They had a severe drought in 1970. Terrible growing season, harvested very little wheat. Bread is a big part of the diet in Iraq, and they used up all of their stored flour supply, so they couldn't make any more bread. But ironically, US aid is now in the news with the new administration and closing down US aid. But when we send US wheat that we have a surplus of, being kind to other countries that are impoverished, we put it in big 100-pound bags. And so that those bags, when they get wet, won't rot, and animals won't get into them, there is monomethyl mercury compound which kills rodents in a very low concentration in the wheat in the bags. And there's written in English or another local language, do not eat, use for planting only. If you plant the wheat germs, the wheat seeds, when that grows into a plant that makes flour, wheat, it's not toxic. But if you eat the flour raw or use it for making bread, it's much more concentration and it gives you monomethyl mercury toxicity. And in 1971, there was the Iraq poison grain disaster where, desperate to grind that seed wheat into flour so they can stop starving and make bread, every day they ate bread, they were getting a fresh dose of monomethyl mercury from the flour that was ground from the wheat seeds that Evan. And look at their symptomatology. It was the same as Our Lady. Paresthesias, numbness of the skin, ataxia, discoordination, visual loss. Just like our patient, just like Minamata, Japan, all going back to monomethyl, or in our case, dimethyl mercury toxicity. It was the largest mercury poisoning when it occurred in 1971 and 1972. And just a few months ago, I was able to find a picture going back to the 1970s of a bag of the grain. And you could understand local folks in Iraq knew that that was grain seed, knew that it was colored pink, also a warning not to eat it, but they couldn't read this. They could not read this warning, do not eat this. It is toxic. Do not eat the grains. Just couldn't read it. I found one article back from the early 70s that looked at the concentration of mercury unspeciated in their blood. Remember, our patient was more than 4,000. And I found some patients who had been eating this poisoned flour for 2 months, every day, 3 meals a day for 2 months. Not just one tiny spill 5 months ago, but eating it every day. They got their blood mercury concentration up 3,000, 4,000, even 5,000. And then I looked, well, what were their symptoms? Well, they didn't become symptomatic for more than a month, but they had been eating the stuff every day for 2 months, so maybe that's why it occurred faster. They had paresthesias, abnormal sensation. They had discoordination. They had tunnel vision. They had dysarthria. They had hearing defects. And at the highest concentrations, and this is what I was really worried about with her rapid progression, I was worried she might die. And now for the first time, if you can see where my pointer is lower right, 28% died at the time they wrote the paper. I'm sure there were more after the paper was published. So we decided to use dimercaptosuccinic acid, approved by the FDA. You can see at the top, evidence had been provided to the FDA to prove its safety and its utility in lead poisoning. It's now approved for that. Back then, it was using off-label. Mercury poisoning, the same thing. Its utility had been shown, but there was not formal approval for that. You are legally allowed to use it if you think that's the best thing available for your patient. Well, I don't like treating patients when I have no evidence published in the medical literature that what I'm doing makes sense. But I spoke to as many mercury experts across the country as I could, and they put me in touch with a paper in the scientific literature, not human science, but animal science, showing that if you injected monomethyl mercury into the peritoneal cavity to make sure it got in, where it could be easily absorbed through the large surface area of the rats or the mice in this case, and then you came back 4 days after and sacrificed them, already their liver, their kidney, their brain, and their blood had very, very highly elevated levels of monomethylmercury. And those were no treatment. They then kept the mice for 12 days and then sacrificed those with no treatment. This was 4 days later. This is 12 days later. Very high levels of monomethylmercury in all of those organs. And they tried 4 different chelating agents given to the mice. By far, as you can see, the most effective at mopping up the mercury and preventing it from getting into the organs if given 12 hours after the injection. If you see the patient right away within 12 hours, was dimercaptosuccinic acid. So given that it seemed to be safe and was FDA okay with, but not approving use in lead and mercury poisoning, we got hold of that agent and gave it to our patient. By this time, she had lapsed into a coma, which she remained in for the next few months. This was now in February, and she remained in a coma until June, so February through June of 1997. We gave her multiple 20-day cycles, the recommended length for other poisonings with DMSA, and just to try a different chelator, hoping it might be more effective, 1 cycle of N-acetylcysteine with those attractive cysteine groups. I'll show you in a minute a dramatic decline in the level of mercury in her blood. Of course, we couldn't and didn't do brain biopsies to measure how much was in her brain, but we eventually got that information. She had lapsed into a coma, basically a chronic vegetative state with periods of extreme agitation. The family had a living will from her, and she said, you know, if I'm ever in a car accident and I'm paralyzed, but my brain is still with it and I enjoy seeing my kids and my husband and talking to them, keep me alive. Give me, tube feedings if you have to. If I am ever in a car accident with brain damage, but they're optimistic I'll recover, please keep me alive. But if I'm ever in a car accident and my brain is severely damaged and I lapse into a coma and the neurosurgeons say I will never wake up, please do not keep me alive artificially. Well, we didn't know with this if she would ever wake up. We were very doubtful, but her family wanted her kept alive with excellent nursing care from February, right, when we discovered this in late January, through June of 1997. She got such good nursing support in our hospital, she never developed a urinary tract infection, skin breakdown, cellulitis, and was able to maintain most of her body weight. She basically was never responsive. She just had periods from time to time of loud vocalizations, but that was never in response to human contact, tactile contact, or speech, unfortunately. We had a very smart local director of lab and chemical safety, and he went through her lab notebooks, and she had said she remembered a spill back in August of 96. Remember, she presented in January of 97, and she thought it was sometime in August, and they pulled out her lab notebook, one of those green ones that you can't rip out pages, so it's permanent. And she reported that spill exactly as I described it in her notebook. In fact, my description is based on her detailed description in her notebook. We tested all of her grad students, postdocs, colleagues in her department of medicine. We did swabs throughout her lab. The only places, excuse me, I'll turn this off. The only places that were positive were her, the fume hood, and the speaking side of her telephone, which we believe was mercury vapor in her exhalation when she was talking that embedded itself in that phenolic plastic resin. But we wanted to confirm that that was her one and only day of exposure. And I wonder if anybody can think of a way to confirm that her one and only exposure was way back on August 14th. Does anybody want to unmute and speak up a way we could work back in time? Okay, well, what we decided to do in my last 5 minutes is her hair was 30 centimeters long, and hair grows at 1 centimeter a month. So every centimeter comes from a different month of her time. So we could easily go back 8 months in time, cut her hair into 2 millimeter fragments, put them each in a separate baggie, and elute the mercury from those fragments on a weight-based basis, and find out the relative amount of mercury, nanograms of mercury per milligram of chopped up hair, 2 millimeters by 2 millimeters, and go back 8 centimeters 8 months ago. And we could see that she had a little bit of mercury, like we all do. And then there was a sudden, rapid monophasic increase, like one injection of mercury subcutaneously, that over the next week peaked in the blood, and then mono exponential decay as mercury slowly then came back out of tissues and was excreted with the help of chelation, starting, well, 5 months would be 150 days. So this was her decay. So it appeared there was only one exposure. This is just showing chelation hugely increased the excretion of her mercury, organic mercury, into her urine. Her blood levels came down, but she did not wake up. And when she eventually died on June 11th in 1997, it was big news in Hanover, New Hampshire, which is where Dartmouth is, which is where she was a professor. And it was big news in Hanover and in newspapers across the country. Dr. Kaplan, the medical examiner, did do an autopsy on her. We wanted to make sure what was going on, to be sure our synthesis of the case was right. They took the case, they don't have to. And Dr. Clarkson, once there was an autopsy, we got tissue from all over the brain, the liver, and the renal cortex. And I'll just focus you down here. All of those tissues had levels 60 to 100 times the level of normal after 5 months of chelation. So you can imagine how much higher it was at the peak time when she presented for care. Dr. Hickey was head of our neuropathology group. All of her brain tissue, everywhere he looked under the microscope in a slice of brain tissue, more than 50% of the cells had died off and the brain had shrunken, but the area most seriously affected was the cerebellum. And here I'll show you a normal cerebellum on the right of my screen. And you can see these folia, these white brain tissue, go all the way out to the edge, a little bit of black space in between. Her brain had more than 50% of the tissue vanished, gone at autopsy of her brain. So the postscript, this is a brief accidental exposure to a tiny volume. We later found that latex gloves are worthless. Dimethylmercury, which we tested safely, got through those gloves within 15 seconds. So although they were on her hand, they really offered her no protection. In fact, if the liquid got under the glove, that probably, until she took the gloves off, enhanced its absorption. The best chelator to this day remains unclear. I probably would use dimercaptosuccinic acid again without any further evidence of something being better. And I thought I was done with this, but with this case, but in 1998, I stumbled upon a paper in the Archives of Toxicology about 3 chemistry workers cooking up monomethyl and dimethyl mercury for scientific use. They got the same disease she did. You can see in yellow everything that our patient got, they got. Their blood levels ranged between 2,000 and 4,600. Our patients, that was right when it happened, our patient's level was that high 6 months after it happened. They also had no benefit from chelation because it was discovered about a month, you can see here, up to 48 days after they last worked with it. And then I really thought it was over, but then I got this email just a year or two ago. I'll read it to you, and then that's almost my last slide. Dear respected sir, I'll paraphrase. I am a doctoral student in India. We have a group of 4 doctors who do research on the biology field. We want to conduct research on snail brain neurons, and for that research, we need dimethylmercury to poison the neurons. My question to you is, please tell me if at the time of research experiment procedure, if I spill 2 drops on my hand, is it sure that that will kill me? And I wrote him back and said, please don't use that. It's so highly toxic. Please find a different chemical if you possibly can. Here's my final note about Karen Wedahan. This is her. She was a gifted, talented woman on the faculty, beloved by her undergraduate students and graduate students, founded the Women in Science program at Dartmouth College. I mentioned her research area of interest, environmental toxicology. Why am I showing you her pictures and her name? During the 7 days that I was her physician at the hospital, she sensed that she might be dying. She sensed that she might lapse into a coma. She knew about toxicity from her reading of mercury. And she said, please tell people about my case. You have my permission to use my name. I don't want anyone else to have a lab accident with any toxic heavy metal and have to go through this. So I remain indebted to her for what she taught me. There's a lot of this toxicology I didn't know at the time, and for wanting the warning to go out in a conference such as this. So that's my last slide. I will stop here. There might be 1 minute for a question or two if you could read those to me. I'm not sure I'm tracking those yet on Zoom.
I've been keeping an eye on the chat for you, Dr. Nierenberg. Thank you very much for a great presentation and just a thorough workup with your patient. Jeremy Berger asked, are current industrial safety standards and protective measures sufficient to prevent accidental exposure to dimethylmercury, considering its extreme toxicity?
I would say probably not, and still permit you to work in a lab. Here's why I say that. The fume hood failed to offer proper protection, and we checked the fume hood and it was working properly. It was venting all of the vapor to exhaust. We did confirm, as I mentioned, using latex gloves, that the dimethylmercury was able to get through it within just a few seconds. The only gloves that worked were double gloving with a rubber glove on the inside that was physically protected by a metallic glove woven into a fabric on the outside, but they were so clumsy, they didn't allow pipetting in a fume hood. So the protective gear that will protect you, and using a self-contained breathing apparatus isn't a bad idea either, doesn't allow you to do the delicate work in a fume hood. So at this point, I don't think there's any way to handle it safely.
Indeed,
By
a
the way, other
fascinating case.
reagents have been discovered that are not toxic that can be used for standards for NMR spectroscopy. I'm not aware of another chemical that is as highly selective for neurotoxicity as dimethylmercury.
Understood. Well, Dr. Nierenberg, thank you so much for your time, as well as taking a moment to exalt Karen Waterham's work.
Yeah,
Very much appreciated.